During packaging for release, the Golgi apparatus accidentally spills those enzymes inside the cell in the cytoplasm. What do you think would happen to the cell if those enzymes spilled in a normal cell? I heard one answer. Bravo? You guys agree with that? So remember we talked about how normally our pH is a little bit more alkaline. And so if we have a normal cell, it's not injured, it shouldn't be acidic. So if that cell, if those enzymes spill open, hopefully it shouldn't cause any issues. Now if we had an injured cell, right, if we had lactic acid buildup and we decrease that pH down a little bit and then we spill those enzymes, well some of those enzymes, those lytic enzymes, they like to work in a decreased pH. And so that would usually cause cell injury. In this case, if this happened, shouldn't cause any issues. We should be able just to kind of get rid of it, but that's typically what happens when a normal cell accidentally spills those open. All right. So, what is the common pathogen associated with caseous necrosis? See? Yeah. So we talked about how this is typically associated with TB. You can see it in fungi as well, but most of the time you're going to see this with TB. All right, I'll let you guys read that one. I know you guys haven't had, we haven't talked about GI stuff quite yet. That will come eventually. Just based on what you see there, what you know, what we learned from yesterday, what do you think is most likely? And also to think about this, what did I give you, or what is in the question, and what is not in the question? Because that's a common thing where we try to, well, I don't know, what's going on with the blood, right? If I didn't give it to you, it's not in there, then you don't know, so you really can't imply, right? You shouldn't be able to imply that maybe something else is going on. So based off the information you have, what do you think could be the most likely findings? C, D, C. So did we talk about cancer a little bit, but we didn't talk about paraneoplastic syndromes, right? That's typically what you'll see with C. D. Yeah. So in this case, what this patient has is pancreatitis. I know you guys don't know that yet, right? But whenever we have damage to a cell, remember I told you that as long as the blood calcium is normal, which it should be in this case, then that calcium can deposit in that damaged tissue and calcify in there and it kind of sometimes grow, right? Now if we had the opposite, if we had a condition that was causing too much calcium release, and I would give that to you if it was a question. I would say, hey, this blood calcium is whatever, and I would give you a reference range, and that's when you could say that maybe there was a type of secondary hypercalcemia versus systemic hypercalcemia. Make sense? Yeah? All right. Yeah. So we talked a little bit about inflammation yesterday, so today we're going to kind of get into the details of inflammation. And you're going to see inflammation a lot. You've probably experienced inflammation yourself. But inflammation is one of those things that kind of hints to us as PAs, as clinicians, that something's going on with our patients. There's different things that can influence inflammation. Sometimes we can have localized inflammation, and sometimes we can have kind of systemic inflammation where we kind of get these fevers, these chills, And then not only that, there are different types of inflammation that you're going to see in the clinic. And then finally, you're going to see that inflammation is very, we definitely need it, right? It's protective, and we need it for tissue healing. But sometimes it can get in the way of tissue healing and cause other issues. So, like I told you guys already, inflammation, we need it. It's a normal part of our body. We evolved to develop inflammation for a certain reason. It's typically protective. If we get some type of injury, we get trauma to our skin, if we, twist an ankle, we want inflammation to come in. We want inflammation to do its job, because what it's going to do is going to bring immune cells. It's going to bring proteins. It's going to bring things that we need to kind of heal our body. But sometimes that inflammation can be harmful, and we'll talk about autoimmune diseases eventually. But sometimes if we develop an autoimmune disease, that inflammation can start damaging our body. But understand that inflammation is not a disease. This doesn't mean if you have inflammation, that's not the problem. What you have to do is try to figure out what's causing that inflammation. Now, sometimes it's going to be obvious. Sometimes your patient's going to come in and they're going to say, "Hey, I fell down some stairs, I hurt my knee." Okay, that's obvious. But sometimes you're going to get patients that come in and like, "Hey, I'm having this random, swelling, this redness of skin," and they don't know what's causing it. And so through your history taking, hopefully you're able to kind of figure out what's going on there. But again, inflammation is not a disease itself. It's a manifestation of something going on within the body. Now, when we talk about inflammation, we typically think about it in acute and chronic forms. Acute typically lasts for a few days, whatever's causing it. Our body does what it needs to do and it gets rid of it. And most of the time when we have acute inflammation, the main white blood cells you're going to see initially are neutrophils. Neutrophils, they're the predominant white blood cell in our body, and they very quickly mobilize to the area that's causing the problem. But over time, if whatever's causing the inflammation continues, then we're going to develop chronic inflammation. And that's typically due to some type of persistent infection, maybe some type of autoimmune disease, or maybe you stepped on some type of nail or some type of thorn or something like that, and you have some foreign body in you. So our body's going to say, "Hey, that shouldn't be there. We need to keep trying to fight this off." But those things are hard to get rid of. But chronic inflammation is one of those things that just can persist, and there's typically a reason for it. And again, our job is to try to find that reason. But most of the time when we have that, if we were to take a biopsy of tissue that's chronically inflamed, we're going to see lymphocytes and macrophages most of the time. And that's because neutrophils, as we'll learn, they are very good at doing what they do, but they die off pretty quick. As opposed to macrophages and lymphocytes, they persist, they can hang around for a while. They don't die as quick whenever they're trying to fight off infection. And then we'll talk about the next lecture, lymphocytes, they're more targeted. They're more targeted to what's going on. They can make antibodies, some of them can. And so that's why these guys persist longer than our neutrophils. So that's why you'll see that in chronically inflamed tissue if you were to biopsy it. So we're going to talk about the inflammatory process, and we're really going to just focus on acute. Because if you understand acute, then you'll understand chronic. Because essentially all chronic is just acute that's persisting. So if you understand acute, you'll understand what chronic inflammation is. So obviously, there's a number of things that can cause inflammation. Bacteria infections, that's probably the most common thing we're going to see. But sometimes, if you have some type of physical trauma, if you get burned, or like I mentioned, if you twist the ankle, that can cause inflammation, any type of damage to our tissues. Splinters, right, talk about that. If you get some type of foreign body and you can't get it out, your body's going to say, "This should not be here, I'm going to try to attack and get rid of it." Sometimes it's very rare, but it can happen if a patient has surgery, and they accidentally leave a gauze in the patient, and that can cause inflammation. If anybody's ever taken out sutures before, you know there's a certain way to take them out, because if you leave that suture under the skin, that patient's going to come back eventually and say, "Hey, I'm having a lot of pain here, I'm having a lot of redness." That's because that suture is causing a foreign body reaction and causing inflammation. So again, a number of things can cause inflammation, and we have to figure out what's causing it. So when we talk about inflammation, there are three major steps. Now there there are a lot of other little steps within inflammation, but I think it's helpful just to kind of know the three basic ones. So first off, there's some type of trauma, some type of injury right to our body, and it's not on here, but I think it helps to kind of just make this clear that within our body we have these cells. We have mast cells. Maybe you've heard of that, or you'll hear about that in a lab. But our mast cells are kind of strategically placed within our body. We have trauma, we have damage to our cells. I told you guys yesterday, right? Our body doesn't like to see the inside of our cells, so they release proteins. These mast cells see these proteins and they release histamine. Histamine is a very, very potent vasodilator. So whenever we have trauma, those mast cells are activated, they're going to release histamine, and it's going to cause our blood vessels to vasodilate, cause them to engorge and get bigger. And we want that to happen, right? Because if there's something going on somewhere in our body, we want to mount that immune response. We want to bring as much blood flow in, as many white cells as we can, just to try to fight off that infection. So the cells vasodilate, or the blood vessels vasodilate. Now what that does is, again, it's going to engorge those capillaries to bring in more blood flow. And what that eventually does is it slows down our blood flow. Now it slows it down because as we engorge those capillaries, you see there in the middle picture, you have little, what are called gap junctions between our endothelial cells. Those are our capillary cells, right? And by engorging that blood vessel, it's going to open up those endothelial junctions. It's going to allow fluid to kind of seep through. And that's why you see edema or swelling whenever there's some type of injury to our body. But by doing that, as we push out fluid, we're slowing down that blood flow. Now what that allows is our white blood cells to kind of go to the side of that endothelial cell and start to kind of migrate towards those gap junctions. That make sense? So when it does that, it's going to allow the white blood cells to eventually escape. Well, as we dilate those blood vessels, we open up those gap junctions, we're allowing those white blood cells a place to actually escape through, but we're also allowing proteins to get through. And typically, those are our complement proteins, which we'll talk about here. Sometimes we have immunoglobulins that will escape. Okay.
So with the permeability increase, first of all, it says lung engorgement, and the lung is a component for a mediator. So is that engorgement from the slower flow, so you basically have more pressure inside the microvasculature,
Exactly.
so it's actually expanding, physically expanding.
Exactly. Yeah, so if you think about it, right, if I go like this, and these are my gap junctions, well, everything's closed. Now, if I try to open up that space more, now I'm creating that space, right? So that engorgement is actually helping open up those gap junctions to allow those white blood cells to escape. Now, there's other things that will cause it, and I'll show you here in a few slides. It's not just that, but that's the primary means. So like I was saying, we allow proteins to get through, which are going to assist in trying to fight off whatever's causing the issue. So talk about complement proteins and immunoglobulins. And then as those white blood cells kind of get to the side of the endothelium, like I said, they can escape through those gap junctions through a method called chemotaxis. So when we damage tissue, certain what are called chemokines are like little chemical signals to our body. Those white blood cells are going to follow those chemokines to that site of injury and do their job, whether it's eat bacteria or release other type of inflammatory mediators. They're going to call in resources to help fight off what's going on. And that's why you see if you've ever been bitten by like a mosquito, you notice, right, the area is red, it's a little swollen. That's what's going on here. Where you have increased blood flow through, which is causing that redness. It may be a little warm because our blood is warm, and if we're bringing more blood to it, it's going to feel warm. And then if we're letting fluid out, then it's going to swell, right? Now that fluid is out of the blood vessel, so it's in what's called interstitial space. So that's outside the blood vessel. So that's why certain conditions you'll see a bit of swelling going on. So again, just a kind of visual representation, we have vasodilation. It's going to open up those gap junctions, and then our white blood cells are going to escape. And if you see on that picture towards your left here, right over there, or left over there, you see the white blood cells kind of going towards the endothelial lining, and then you see those smaller little cells that have little dots in them. Those are your mast cells. So they're releasing that histamine, helping that endothelial cell to vasodilate. And you got that chemotaxis that's how we call white blood cells moving through our tissues, and it's being drawn by these chemotactic factors, chemokines. It just signals to the white blood cells saying, "Hey, come here. Something's going on. We need you to come and try to fight off what's causing this issue." So when we have inflammation, we typically have 5 signs of inflammation. We have heat. That makes sense. I just told you guys that our blood is warm, and so we're drawing more blood to that area. It's going to feel a lot warmer. We have redness, so we're engorging those blood vessels. We're bringing in more blood, so the area is going to look a lot more red because our blood's flowing through there. We have that swelling because we're having fluid escape those gap junctions into our tissue. We have pain. Now this pain is it's typically due to a few different things, but one of the primary things is if we have swelling, we can actually cause pressure on our nerves that tell us if we're feeling pain or not. So that swelling can cause that pain that we're feeling. Some other things, some other mediators of inflammation will cause pain, and I'll show you that here in a minute. But we also have loss of function. Now it's not a true loss of function. If you have somebody coming in, for example, with knee pain, and they come in and say, "Hey, I can't move my knee," well, they can't move their knee because maybe they're having pain, maybe they're having swelling, so they're trying to protect it. But if you were to go and say, "Really, let me take your knee, let me try to move it up and down," you can make it function. You can make it actually work. You can make it do its job. So it's not a true loss of function. It's just more of a protective mechanism. So a patient's going to come in and say, "Hey, I hurt my knee," and you're going to be, "Well, okay, I need to check your range of motion," and they're going to say, "I can only go this far." And then you, as the clinician, you're going to do passive range of motion. You're going to try to see how far you can go with that knee. And you're going to see that you can move it a lot more. Obviously, you don't want to hurt the patient. But that loss of function is it's not a true loss of function. It's more of a protective mechanism that the patient's going to experience so they don't hurt themselves. So this is a very busy slide. It's an FYI slide, so don't memorize it. Don't try to figure out what goes where. But really the main point of the slide is to show you that there are some inflammatory mediators, which all those are just they propagate inflammation, they kind of control inflammation. There are some that are made in the cells, and there are some that are made in the liver. But really what I want you to focus on is there are some inflammatory mediators that are pre-made. And that's good, right? If we have an injury somewhere, if we have some type of damage, some type of trauma, we want inflammatory mediators ready to go. If we're waiting on them to kick in, then we are potentially increasing the risk that we have infection somewhere, that our tissue is not healing. So we want things ready to go, pre-made, just in case that injury occurs that causes the inflammation. And on the opposite end, we have ones that need to be made. And that's fine. As long as we have those pre-made mediators coming in, while they're doing their job, then the ones that need to be made can start doing their job, trying to be made. That way, eventually, when those pre-made ones are done doing what they do, those newly made ones can start doing what they need to do. So we want pre-made mediators because we need that as soon as we get injured. So the ones I want you to know, though, so histamine. We talked about that briefly with the mast cells. They're also made in other cells like our basophils, which are essentially our blood forms of mast cells. Platelets also make it, but their job, like I said, was to cause that vasodilation to increase that permeability of our capillary endothelium. The thing with these, though, is that they don't last too long. 30 minutes, give or take. And if you, again, talking about the mosquito bite, if you've been bitten by a mosquito, it's going to be itchy, it's going to be red for a little bit, but after a while, it's going to stop itching, right? That's because that histamine starts breaking down and not causing any more issues. And then we have ones that need to be made, right? That's the arachidonic acid. Now, arachidonic acid, that's already in the cell membrane. It's in a lot of cell membranes, but this focuses on our white blood cells. So arachidonic acid is just sitting there, not really doing much. And then whenever that white blood cell starts to become activated, then that's when it's going to say, okay, we need to take that arachidonic acid and do something with it. And it's going to go down one or two pathways. We have the LOX pathway. That's what makes our leukotrienes. And again, that it's kind of like the bat signal, right? It's a signal to our white cells saying, hey, we need reinforcement here. Please come help us. Something's going on. We have an injury. Bring in as many resources as you can so we can try to fight this off. And then going back to your question in the back, so you talked about the permeability, we talked about the engorgement. What these leukotrienes also do is they attach to our endothelium. So they get on those cells and they cause those endothelial cells to actually contract, which kind of opens up that gap more. So not only do you have the engorgement, but you have these leukotrienes that help increase that permeability. Then you got your COX pathway. You got prostaglandin and thromboxane. Prostaglandin, that also helps with vasodilation and also helps with permeability, but it's also a big factor in how we perceive pain, and it tells our body to start causing fevers. Because even though fevers are not fun, right, and they can be dangerous at times, whenever we cause fevers within our body, we're essentially making our environment for any pathogens, we're making it inhospitable, right? If you're out in the desert somewhere, you're not going to feel too well. Well, if we have an infection and there's bacteria or virus in our body, if we increase that temperature, we can cause those bacteria or those viruses to start breaking down to a certain level. And then we have thromboxane. That helps with platelets. Go ahead.
Sir, is it a deal you're going to do lots or are you going to do the constantly?
They both occur. Yeah. Now they occur at different levels, and it depends on the severity of the infection, but they both will occur. So thromboxane, that helps with our platelets. It makes our platelets a little bit more stickier. That way they can start to clump up together, and if there's bleeding going on, cause that blood clot. And if have you guys gotten into the pharmacy, like Cox and all that kind of stuff yet? No? Okay. So anti-inflammatories like naproxen, like aspirin, they actually, you'll learn this, they actually inhibit that COX pathway. So that's why we give it to patients whenever they're having pain, whenever they're having fever. If we give them a COX inhibitor, like ibuprofen, like naproxen, like aspirin, then we can potentially reduce their pain, reduce their fever. Some of those medications work more along one pathway than others. For example, aspirin is more targeted towards trying to stop that thromboxane, versus ibuprofen and naproxen, they're more so pain and fever. If you vary the doses, and you can impact those pathways a little bit more. It doesn't matter for right now, but that's why we give these drugs. We're trying to stop that pathway. We're trying to stop that inflammation. That way, our patients feel better. All right. So then, kind of going on to what our liver makes, what's kind of floating around in our plasma. We got bradykinin. And if you ever hear the word Brady in medicine, all that means is that it's slow, right? And it makes sense. We don't want our histamine, I told you guys histamine only lasts for a little bit. Well, we still need to propagate inflammation because we're not going to heal within 30 minutes. So then bradykinin comes along and it helps continue that inflammatory process by doing what histamine also does. It's going to help vasodilate those blood vessels so things can get out of those vessels and start attacking what's causing inflammation. It's kicked off by the coagulation cascade, and you guys will probably have to memorize that in lab. I'm not going to ask you anything about the coagulation cascade, but that's how it gets kicked off. But it also helps cause pain, right? So I told you there are some things that can cause pain. This is one of those things that can lower our threshold for perceiving pain and tell us something's going on wherever the site of injury is at. And then we have the complement system. And like I told you guys yesterday, that complements our immune system. It's going to help fight off whatever's going on. It's going to attack whatever infection may be going on. And it does it through different ways. We got vasodilation. Now, it doesn't necessarily, so the complement proteins, they don't necessarily cause vasodilation. But in a kind of a backdoor method, they can activate mast cells, which can cause vasodilation. It helps with phagocytosis. So what complement proteins do is they'll attach to bacteria, which makes them easier for our white blood cells to actually phagocytize and try to get rid of. So it's kind of like sticking a fork in food, right? If you can eat food with your hands and you're going to get messy, but you can do it, it's a little bit harder. But if you attach those complement proteins, which is called opsonization, it's a lot easier for those white blood cells to attach to whatever it needs to get rid of. And then finally, we got the membrane attack complex. That's essentially where our complement proteins come together and they punch a hole in the cell membrane of whatever's causing this issue. And by punching a hole in that cell membrane, it's going to cause that cell to lyse and die, and then allow our white blood cells to come and kind of eat the rest of it. So the complement system. So there's 3 pathways, right? We got the classic pathway, the alternate pathway, and the elective pathway. There's a lot of steps here, right? And you know, if you look at the classic pathway, you got C3A, 4A, 5A, you got C3B, and then if you look at the alternate pathway, you got endotoxins and venoms, and the lectin pathway, you got carbohydrates, and they activate by binding to bacterial surfaces. I don't care about any of that. I don't care if you know all the steps in the complement pathway. What I want you guys to know is that whether it's classic pathway, alternate pathway, or the lectin pathway, they're all gonna end in that membrane attack complex, that MAC, right? So whether you have a bacterial infection or you get bit by some type of snake venom, it doesn't matter. All of them, all 3 of these pathways are going to end in the membrane attack complex. So again, don't memorize this stuff, but it's just to kind of show you that as it goes through its entire pathway, that Big Mac is going to come through, and he's going to punch a hole in those cells, and those cells are going to lyse, and then you're going to get rid of that infection. But the problem with the membrane attack complex, the big problem with it, is that sometimes it doesn't just attack those cells that need it, whether it's a bacteria or a virus-affected cell. Sometimes it can damage other cells that are close to it. Now, normally our body is able to control that. We have different factors that help stop that membrane attack complex from going to other cells. But if those factors fail, then we can kind of get damage to healthy tissue, which can cause other issues later on. But again, most of the time our body does a pretty good job on stopping that. But you'll see here in some type of autoimmune diseases that it can't do that, and then that MAC attack is going to come through and it's going to punch holes in healthy cells and cause other issues down the line. So regarding inflammation, so we have different cells that we need to actually help us go through inflammation. Like I told you already, we have neutrophils. These are the most you're gonna have in your body, and they are very, very important for fighting off bacterial infections. And they're the first cells that are going to appear when you have some type of inflammation, because they move quickly, and we want them to move quickly. Because if we get stuck by some type of dirty needle and we introduce bacteria, we want those neutrophils to come through. We want them to start eating up and start destroying those bacteria as soon as they can. And when they do that, you'll see in this top picture here, you see these little like purple dots. Those are little granules, and when the neutrophil actually eats the bacteria, it starts to cause these granules to diffuse into that bacteria and start to break it down. And those granules have, remember I told you guys about those free radicals? These granules have those free radicals, and those free radicals start destroying that whatever it ate. But also too, they also have other jobs. They call in resources because neutrophils alone sometimes can't fight off the infection. So they'll send out cytokines to call other white cells to come along and help us. And then we got eosinophils. Now typically these guys present a little bit later. They're a little bit slower. They don't come as quickly as our neutrophils do. Typically take about a couple of days. And that's fine, because most of the time when you have some type of condition that causes eosinophils to come through, they're not too serious. When I say too serious, they're not going to cause infection, death right away. So if you think about allergies, right? Allergies just have some type of pollen or something like that. These eosinophils come along and they help with, and they interact with basophils to cause the inflammation that we experience with allergies. And then parasites. I know you guys took microbiology already, but typically parasites, if you get them, they're not going to kill you right away, right? And eosinophils have special granules that are targeted towards parasites, but they actually attach to the parasite, release those granules and try to kill it that way. But so these guys are a little bit slower to come along, and that's fine. We don't need them to come quickly, but our neutrophils we definitely do. We want these guys to come right away because they can kill the bacteria right away and call in resources. All right, basophils. So these are very, very prominent when we have allergic reactions. We'll talk about this in our next lecture, but basophils, they have these little attachment sites for IgE antibodies. And so IgE antibodies are very important for attaching to our basophils because when they attach to that, it's going to release their granules, which contain a ton of histamine. And that's going to cause that vasodilation. It's going to cause that inflammation to propagate. But super important when it comes to allergic reactions. You'll see it you'll see it if people have asthma. When we talk about pulmonology, you'll see that. And then anaphylaxis, people who have that severe allergic reaction. Again, basophils are very prominent in that because of that release of histamine. Now, important to know, make sure you guys know this, when basophils escape our blood and they go into our tissue, they change into mast cells. They still do the same thing, they still release a lot of histamine, but they're just different types of cells, which we call mast cells. And then we got macrophages. So in the blood, our macrophages are actually our monocytes. And then when they escape our blood and go into our tissue, they're macrophages. We call them macrophages. And monocytes can phagocytize as well, but macrophages are a lot better at that. So when they escape our tissue and they need to eat something to destroy it, these guys are who you want to get rid of that, whatever that damage or that infection. And I told you guys that macrophages last longer too, right? They present later, but they last longer than our neutrophils. And so whenever you have some type of chronic inflammation, and you biopsy that, you're going to see our macrophages because they don't die as quickly as our neutrophils do. Then you got your platelets. So platelets, these are very important when it comes to trying to stop bleeding. And they're highly responsive to thromboxane. We talked about thromboxane and how that helps kind of make the platelets stickier. So whenever we have platelets, we need them to clump because if there's some type of damage to a vessel, that those platelets are going to be that first source where we're going to stop that bleeding. We need them to clump to kind of create this blockage that way we're not bleeding out. And then we have our lymphocytes and plasma cells. So again, we'll talk about this in our next section, but they have a very, very important role in our immunity. They're what help us make antibodies to certain pathogens, and those antibodies can attach to those pathogens, either destroy them or mark them to be destroyed for white blood cells. And you're going to see this quite a bit. You're going to see an increased number in lymphocytes whenever you have viral infections. And we want that, right? Because if we have a virus, hopefully, if we see it again, if our lymphocytes have seen it, they've made those antibodies towards it, the next time we see that virus, our body can attack with those antibodies and get rid of it quickly. But again, these are going to be more so in your chronic inflammation. You're not going to see these acutely. And it makes sense, right? If we see something for a prolonged period of time, these lymphocytes are going to make antibodies to them. If we can't get rid of them, they're going to hang around trying to fight off whatever's going on. So when it comes to inflammation, there are a couple of outcomes that can happen. Preferably, we want complete resolution. And this is typical whenever you have something that you have minor damage. Maybe you scrape your knee, maybe you bang your elbow. If you have a little inflammation, but the damage is only minor, then most of the time our body's going to return back to normal function. It's going to be able to repair itself, and maybe you won't even notice that you had the injury. However, if there is a lot of damage to a structure, so say you cut yourself and it's not a simple cut, you cut down deep to the dermis, well then potentially, most likely you're going to develop fibrosis, what we call, or scarring, which you probably heard of. The problem with fibrosis is that once fibrosis or scarring develops, it's more so like it's there really to kind of fill in the defect. Once you lose a cell, once you have scarring develop, it's not going to revert back to the normal cell that it was. So you have a loss of function. So if you, does anybody have scars on their body, right? As long as, if you look at that scar on your body, it doesn't look the same. Now, can you still move your, if it's on your hand, can you still move your fingers? Hopefully you can, but if it's in a certain location, then maybe you have decreased range of motion in your fingers. If you have scarring in maybe your brain, right, and we'll talk about here in a second. If you have scarring in your brain, those brain cells are no longer brain cells. They are scar cells, they're fibrotic cells. And so you're not going to get those signals, which can sometimes cause issues whenever, depending on the part of the brain, with movement, with thinking. So that's the big problem with scarring, is that once you have scarring, it's not going to revert back to what it was. Chronic inflammation, so like I talked about, if you have acute inflammation and for whatever reason the cause of that inflammation is persisting, then you're going to develop chronic inflammation. And essentially where that cycle of healing and inflammation gets stuck. Your body's trying to heal, it's trying to go back to normal, but whatever's causing that inflammation, you're not getting rid of. So then it's going to start causing damage again. If you cause damage, then certain cells are going to come through that make scar tissue. And it's this process of just chronic trying to heal damage, trying to heal damage. And most of the time you're going to see this with pathogens that are hard to treat. So TB is a perfect example of that. We can, like I told you yesterday, trying to kill TB is very hard. And so as a result, our body's going to start it's going to keep sending its inflammatory cells to try to fight that off. But it's going to, the best it can do is wall it off. It can't kill the TB all the way. If you have that foreign body that I talked about, if we're not able to take it out, well then our body's going to let us know. It's going to keep saying, hey, there's pain here. You may keep seeing redness, swelling, because we can't physically remove a large foreign body from our body. So for systemic, so we kind of talk about local inflammation, but sometimes inflammation can be felt systemically. And you've all been sick before. You've all had viruses. You kind of felt kind of bad, those fevers, those body aches, those chills. That's because our immune cells are saying, hey, we can't fight this off alone. We need to kind of call in our whole body to try to kill off whatever's going on here. So our neutrophils are big in that. They release something called pyrogens, which go to our hypothalamus of our brain, and that's the control center of our body. It tells us what temperature we need to be at, and when it starts seeing these pyrogens from these immune cells, it causes the hypothalamus to also start producing prostaglandins, and I told you that can help reduce fevers, try to make our environment inhospitable. And the way it does that, so if you've ever had the flu or type of maybe COVID, maybe you feel really cold and really shaky. When we have those rigors, that shivering, that's going to, essentially our muscle cells are just contracting really quickly. And by doing that, it's going to increase our heat in our body. And then it also tells our blood flow to stop going to the periphery, start going to our vital organs to try to protect us. But when it does that, when we have decreased blood flow to our extremities, we're going to feel really cold because we don't have that, we still have blood, but we don't have the blood we normally have in our periphery keeping us warm. So when it starts to shunt back into our internal organs, that's going to cause us to feel really cold, and that's why we feel really cold when we have fevers. If we're trying to fight off an infection, it's going to tell our bone marrow, like, hey, we need to push out more white blood cells. What we have in circulation is not enough, so we're going to get what's called leukocytosis. So if you draw somebody's blood, you will see an elevated white blood cell count because our body's sending off this signal saying, we don't have enough white blood cells to send in more from our bone marrow to try to fight off what's going on. You're also going to have increased blood pressure and heart rate because we're having increased blood flow to our internal organs. And so us trying to push out that blood flow is going to increase that heart rate, it's going to increase our blood pressure, maybe a little bit, not too much. And then decreased sweating. Again, if we don't have the normal amount of blood flow going to our skin, well then we don't have that fluid there to make sweating, to make sweat, so we could have a decreased amount of sweat that occurs. And then in general, our white cells are making those cytokines, right? There's a ton of cytokines, and so I'm not going to ask you to tell me them, but those can act on our brain, make us feel not hungry, make us feel very, very tired, just make us feel bad. So all that together is we call that acute phase reaction. So it's just a generic medical slang. Whenever we start feeling bad, you may hear that as they call it acute phase reactions. All right, so types of inflammation. So there's different types of inflammation. The first one we have is serious inflammation, and this is a mild form of inflammation. And if you look at this hand here, I mean, if I saw this, I wouldn't call this mild, but it's not so much the physical characteristic of what you're seeing, it's more so what's happening at that blood vessel. And it's mild because even though the blood vessels are permeable and they're opening up those gap junctions, they're not opening up all the way, so only little stuff is getting through. Fluids getting through, proteins are getting through, and so we're not, even though it doesn't look mild, if you go down to that cellular level to those blood vessels, it's only opening up those gap junctions a little bit, so that's why we call it mild. Typically, you're going to see this with physical agents. When I say physical agents, if you burn yourself, you're gonna get serious inflammation. Typically, with partial thickness burns, write this down. They're also called second-degree burns as well. And we'll talk about burns when we get into the dermatology session. But if you have second-degree burns, you're gonna have serious inflammation. If you touch something like poison ivy, that can also cause serious inflammation as well. And then some viruses like herpes can cause this as well. But the big thing is that you're not opening up those blood vessels all the way, so that's why we call it mild. And then you got fibrinous inflammation, and this is more of a severe inflammation because we're opening up those blood vessels more. So as we do that, we're letting more things through. We're letting white blood cells through, we're letting something called fibrin, which helps with clotting as well, but if that fibrin escapes, it can cause this kind of white webbing, kind of mat-like appearance. And something you're going to see in clinic is strep throat. So strep throat is very, very inflammatory. And if you were to look at the back of somebody's throat, look at their tonsils, you would see kind of this white, exudate, kind of thick, stuck on, appearing looking secretions on there. And that's an example of fibrinous inflammation. So it's more of a severe inflammation, and it's severe because we're allowing more things through our blood vessels to fight off whatever's going on. And then we got purulent inflammation. So this is typical of abscesses. There are certain bacteria that can really, really call in our neutrophils. Our neutrophils see these bacteria, and they're going to come attack. They're going to attack in force. And when these neutrophils come in and attack, they are eating these bacteria, they're destroying them, but in the same way, in the same process, they're also dying. So neutrophils are doing their job, they're killing the bacteria, but themselves, they're starting to break down, starting to die. And then I told you guys yesterday about that lytic inflammation or lytic necrosis. That's what's happening here. Tissues are dying as well. So as a result, if you were to pop this thing open, this thing will be watery. It's going to smell really bad too. It's going to be very turbid because you have a lot of white blood cells in there that are dead. You have a lot of dead bacteria. You have a lot of debris from tissue damage. And that's what essentially an abscess is. That's what pus is. It's just a mixture of all that stuff together that leaks out or kind of forms in a pocket of tissue. Most of the time, we're going to see this in our skin, or not our skin, but patient's skin. But sometimes patients can develop this in different organs. If there's a type of infection that gets through our bloodstream and attacks that, by far, you're going to see this in the clinic. And the best way to treat this is to incise it, cut it out, get rid of that pus. Typically, you'll want to leave it open for a few days, just to let it keep draining. There's different ways of doing that, which we'll get into probably in derm. But that's how we treat these things. We cut it open, we express all that pus, and then they come back a couple days later, we take a look at it, oh, it's still draining, we'll clean it out again, and just keep following it until either the pus stops or the incision closes. Most of the time, we'll leave something in the incision to keep it open, just to keep it open, like a piece of gauze or something like that. but that's how we do it, guys. And then we have ulcerative inflammation. So the problem here is that there's some type of damage, some type of inflammation going on at the surface level of our mucosa. And a common one that you'll see or run into is gastric ulcers. So in gastric ulcers, normally in our stomach we have bicarbonate, which we have mucin, which kind of coats the lining of the stomach. But there are some things that can decrease that. So H. pylori is a bacteria. It can decrease the amount of bicarbonate mucin that we make. And our acid, we need our acid in our stomach, but if we don't have that protective layer in there, that acid's going to start damaging those cells in our stomach. And as it does that, it starts to kill those top layer of cells. If it persists, if it keeps going on, then that damage is going to start going downward, down deeper into the essentially the base of the stomach, and potentially it can cause a perforation or a hole in the stomach, right? So, but the big thing here is that inflammation starts at the top, and if that problem continues, it can go down to deeper levels and cause problems deeper down, maybe a hole in the stomach or elsewhere. Then we got pseudomembranous inflammation. So this is very commonly associated with a bacteria called C. diff. C. diff, for some individuals, it's a normal flora. Some people have this kind of in their GI system, and it's there and not causing any harm because we have a lot of bacteria within our GI system. Not everybody has this, but some people do. And if we have a lot of bacteria in our GI tract, that kind of stops that C. diff from overgrowing. But if we give a patient a broad spectrum antibiotic, so we give them an antibiotic that kills a lot of bacteria, well, what that can do is allow those normal bacteria to die, and if they die, then that C. diff that's in there starts to overgrow. And when it starts to overgrow, it releases these toxins that can damage the lining of our colon. And we call it pseudomembranous because it's a combination of ulcerative inflammation, that fibrous inflammation, and the purulent inflammation. And what happens is we get this damage to our top layer of our colon. It starts to make those ulcers, right? But it's a severe inflammation, so we're letting fibrin in. We're bringing lots of white blood cells in to fight off, trap out the C. diff. And if you were to look at it, like if you were to do a colonoscopy and kind of look at the colon mucosa, it looks like it has these membranes on it. It looks like this kind of yellow-white membrane. If you were to remove that, you would see that under that there's an ulcer. So it's a false membrane. It's not a true membrane. So we call it pseudomembranous because it looks like a membrane, but it's not really a membrane. If you were to wipe that off, you would see underneath that there's ulceration going on. And then we have, finally we have granulomatous inflammation. And now this is not a chronic inflammation. This is it's not an acute inflammation, it's a chronic inflammation. Because I told you, TB, right? TB is one of those things that we can't get rid of. And so if we can't get rid of it, our body's going to do the next best thing and create this wall around it. So you're going to see this a lot in TB patients. You may see it in parasites as well because parasites can sometimes be hard to kill. But essentially, we make these little walls of white blood cells that surround the TB, and then other cells come through which can cause scarring or fibrosis. But it essentially puts the TB in a jail cell. It keeps it there, and hopefully it never breaks out. And most of the time it doesn't, as long as you stay pretty healthy. Sometimes certain things can cause your immune system to fail. So if you get older, right, as we get older, our immune system starts to degrade. Or if you take some type of medication that lowers your immune system, sometimes that can lower our immune system. And if we don't have those white blood cells kind of staying there where they need to be to keep that TB in place, well, they can break out and cause other issues. And that's why maybe you've seen some commercials where they say, hey, tell your doctor if you ever had TB, because those medications, those drugs, can lower your immune system. And if we don't have a healthy immune system, enough white blood cells surrounding that TB can break out and cause other issues. Okay, so let's take a 2-minute break and we'll talk about vanilla.
job. Yeah. That's probably what I heard. And I'll leave it. I was watching some guy he was saying he was the strongest.
We didn't start to.
I know which that's their new policy is that we will like the actual film will start after the show. Well, the movie's 2 hours long. That means it's going to be even longer. And since it's the one time the movie itself.
She had herself a
I'd say it's more like it's like just a medium, it's not title. So things are like how the news are how title together.
Oh, but it's a different.
Yeah, we have it more now. I sort of got like a mistake when we pulled out a freaking 30-minute video. I would only wear one on one. I got fucking one. So I would never get. Yeah, I gotta wear double for like you will.
No, actually, I'll tell you my ugly.
I could see you with it though.
Well, I guess I'm ugly stuff. You know me. Tacky ugly. That's my style. I bet only one sold this person.
No, actually, it's a popular item here
Oh, the parents.
All the parents. I was like, I was like, what?
As a souvenir.
It is
I would
a
make,
desirable.
I would make it into a magnet. You might sell more of a magnet than we don't have it shipped to our, we have it shipped here.
It goes shipped to here, and then whoever brings it to the classroom.
Two more slides to get through. Talking about we're talking about wound healing because if we have some type of damage to our organs, our tissue, we want them to heal, right? So before we get into that, just a little bit of terminology. So abrasion, everybody's had abrasion. If you fall and kind of scrape the top layer of your skin, we call that an abrasion. So if you ever see, when we see patients and we're documenting what we see, we don't want to just say like scrape knee, we want to use medical terms. So abrasion is what you call that. Laceration, these are typically from some type of either sharp injury to the skin or maybe some type of blood trauma to the skin. And the problem with lacerations is that sometimes, this one looks pretty straight. Sometimes lacerations can be jagged, which makes them very difficult to close. You got contusions, which is a fancy word for a bruise or ecchymosis. We can also call it that. And essentially what that is just some type of break in our blood vessels under our skin. There's no break in the skin itself, it's just our vessels under the skin, which causes that leakage of blood. We got avulsion. Typically that's from some type of crush injury. Maybe something fell on your hand, it takes like a chunk of skin out. And then we got amputation, which is pretty obvious, right? Dismemberment of some type of limb, which is never good. So when it comes to wound healing, there are typically two types of reactions that will happen. If the injury is mild, right, we don't affect the tissue too much, then it has the ability to fully repair. It's very dependent on the cell type though. So I have the examples here of our skin and intestine, because those cells have stem cells. They have stem cells within their bottom layer that helps replicate and regenerate that tissue that was lost. If you have either deeper damage or you affect certain cells that don't have that ability to regenerate, then that's where you develop that scarring. So I told you about the brain cells, right? If we lose brain cells, they don't have the ability to regenerate. Once you lose those, they're gone forever. Same thing with the myocytes of your heart. If you lose heart cells, they can't regenerate, they can't replicate. So then, as a consequence, we gotta fill in that gap, right? Those cells are dead, so we'll actually lay down scar tissue. And that scar tissue, as I told you, it's not the same thing. It's not going to function as a heart cell. It's not going to function as a neuron. So that's where we start having problems with these. Now, oftentimes, depending on the injury, they can occur together. So you may have some, so for example, skin, right? You may have some damage where it's kind of deep, kind of superficial, so you may see some level of both. But most of the time, it's going to be either the cells are going to regenerate completely, fully repair, or you're going to have some level of scar tissue at the level. So cells, right? So I told you certain cells, it depends on the cell and kind of what it does. So we have cells called labile cells. These are our cells that continuously divide. They always replicate, so if we lose them, not too much of a big deal because they can regenerate. These are going to be found in our skin, our GI system, and our blood cells. And it makes sense. You know, how many times have you gone and scraped your knee or hit your, cut yourself? We've evolved to have cells in certain areas that way. Because if we didn't have the ability to replicate our skin cells, we'd be one big scar, right? And so certain cells have that ability to regenerate. And then you have other cells like stable cells. These are typically our mature cells, like in our liver and our kidney. They can replicate as long as they're not chronically damaged or you don't chronically cause any injury to them. Sometimes if you keep doing that, if there's some type of chronic injury to those stable cells, then you can get fibrosis. But for the most part, they can regenerate as long as whatever causes that trauma, that injury, is acute and it's mild. And then you have your permanent cells. Like I talked about, these don't divide. What you're born with is what you have. So if you lose these, then they're gone forever. And we're replacing now scar tissue to kind of cover up that defect. Now you'll notice here that chemotherapy, radiation, you've ever seen people who've maybe gone through that, they're losing their hair, they're having lots of diarrhea. That's because chemotherapy, radiation, it targets those cells that rapidly divide. And that's what cancer cells do. Cancer cells rapidly divide, so we use that to our advantage to try to kill them, but an aftermath of that is that our labile cells are easily damaged. But the good thing is that those permanent cells, they don't rapidly divide, and so when we give chemo, when we give radiation, typically you're not going to have any problems with the heart, you're not going to have any problems with the brain because those cells don't divide, and so when we give that, those aren't being damaged. Now once we stop the chemo, once we stop the radiation, people's hair will grow back, they'll stop having diarrhea because those cells can regenerate, but that's kind of how chemotherapy and radiation works when we're trying to treat cancer. So wound healing. So we're gonna use the skin as like our example of wound healing because it's the easiest to kind of get your head wrapped around. Certain tissues kind of heal a little bit differently, but the skin itself, it kind of goes through all the stages of wound healing. So that's what we're gonna use as our example. So first thing with wound healing of the skin, you got damage to the skin, you got some type of vessel leakage. We need to stop that blood loss. We need to stop the blood from escaping. So we're going to have platelets come through. They're going to attach to that site of bleeding. They're going to aggregate. They're going to come together. You're going to have the coagulation cascade kick off to try to help build that blood clot. But notice here, the first step here is vasoconstriction, right? So I told you guys that the first step of inflammation was vasodilation. That is true, but if you have damage to a blood vessel, the first step is vasoconstriction. And it makes sense. If we have a vessel that's bleeding out, we need to kind of constrict that so we have a reduced amount of blood going through. It only lasts for a few seconds though. only lasts for a few seconds, and then once that clot starts forming, that's when the inflammation process kicks in. That's when we get that vasodilation. So first step of wound healing is vasoconstriction, and then you get to inflammation, and that's when we have the vasodilation. That's when we bring in those resources to try to fight off whatever may have gotten to our blood system or our tissues around that. We talked about the immune cells coming through. So once you have some type of injury, things are going to get in there. Maybe you'll have dirt that gets in there, some type of bacteria that gets in there, and those immune cells are going to come through and they're going to phagocytize those foreign bodies to try to get rid of it, to try to reduce the risk of worsening infection. A scab is going to form, right? So a scab, all that is just a blood clot. So your platelets, it's going to be dead white blood cells that have died because they were trying to kill off these bacteria, and that's going to form a kind of protective mechanism. That way you're not bleeding out anymore. And then you got proliferation. So with proliferation, you have these other cells called fibroblasts. So fibroblasts are very, very important because if you have deep damage to your skin and to your dermis, right? So you got the epidermis and the dermis. Those fibroblasts are going to come through and they're going to lay down collagen, and that's what makes up your scars. Collagen is what makes up scar tissue. And what that scar tissue does is it acts as a scaffolding. That way that top layer of your epithelium can kind of grow onto it and through it to try to regenerate itself. If we didn't have fibroblasts come through, well then we have this big defect. Maybe you have epithelial cells trying to recover, but there's no matrix for them to kind of grow through or grow onto. And so without that fibrous tissue there, without that collagen, we would not be able to fully heal our skin if there was deep damage to it. At the upper layer, at the epidermis, we have what's called epithelialization, and that's where the basal cells of our skin, they start to grow towards each other, and then once they contact, they start to grow upwards to try to fill in that upper defect. And like I told you, our skin cells, they have stem cells at the very base of them. And so fortunately, we have that because we're able to replace that top layer of skin pretty easily. So here's an example of that epithelialization. So the cells will migrate towards each other. So you got that defect, the basal cells are kind of growing towards each other. Now what happens is, you have the defect, you have the margins of that defect, and the ones that are closest to that opening, they're going to start kind of coming forward. Behind them, behind those cells, you have other basal cells that are replicating. So as these are coming forward, these other ones are replicating until those ones that are coming forward or together finally touch. Once they touch, it's called contact inhibition, and that tells the rest of the cells to stop proliferating, and instead of going sideways, start going upwards. So we fill in that defect at the base first, and then once they touch each other, they start to mature and they start to proliferate upwards to fill in that defect. So that's the epidermis. And then you got tissue remodeling. So this is going to take some time. The epidermis may look like it's filled in, right? But below it, that collagen that was placed by those fibroblasts, they're going to start being replaced by a better form of collagen. Now that better form of collagen it's not the original. It's not the same collagen you had before you had the injury. So it's not as strong. It's still strong. It still has 80% of the strength of previous collagen, but it's not as strong. So during that time though, if you have any type of trauma to the area that's trying to heal, you have a very big risk of opening that injury back up. So you've probably seen UFC fighters, right? They get knocked out or they get cut in their eyebrow. If they go into another fight and they get hit there again, that site's probably gonna open back up because that collagen that was placed down is not as strong. And so that's why these guys typically get kind of repeat injuries in the same spot, because they had scar tissue develop. It's good enough, but if they get hit there again, it's not as strong and it's gonna open back up pretty easily. I forgot to mention one thing. Let me go back here. So let me kind of focus back on proliferation. So the fibroblasts, they have the ability to convert or change into what are called myofibroblasts. So myofibroblasts, they're still fibroblasts, but they have this muscle component to them that actually attaches to the matrix that's laid down, and over time it's going to grab onto that. They're going to attach to each other, grab onto that matrix, and over time they're going to start pulling that matrix together to try to close that scar, try to make that scar more narrow. And when we have that, and I'll show you a good picture here in a second, when that process is still trying to heal, you're going to have what's called granulation tissue develop. Granulation tissue, all it is just it's white cells that are kind of trapped in there. It's those fibroblasts, and it's that collagen. But that's very important because scars like to contract, and those myofibroblasts are what make it contract. So I wanted to make sure I point that out, because I didn't talk about that here. So contraction. So if we have a linear scar, and say we have it over a joint, that's not good, because if that scar is over a joint, like in this person's elbow here, once that scar starts to contract, you're going to lose function of that joint. And so when we have scars that are over joints, we got to be super careful, because if we don't do something to reduce that ability for it to contract, then we're going to have this contraction where they're going to have limited range of motion. So most of the time when this happens, we're sitting in the physical therapy, and the physical therapist is working that scar tissue, they're stretching it out, they're making it through range of motion exercises to reduce that potential for that contraction. But when we have scars over joints, you got to be super, super careful. Very, very common when we have burns. I think you'll get this in dermatology, you should at least. When we have burns that occur over joints, bad thing, because those burns are going to scar down, and when they do, we got to be super careful that they don't cause any issues with range of motion. Now, if we have scars that are circular, and typically you'll see this if a patient has surgery, maybe on their intestines or maybe somewhere near their esophagus, that scar can actually become smaller, so it can become narrower. And if that happens, it can impede that lumen of whatever is causing the scar around. So if you have a scar around your esophagus when you try to eat, you're going to feel like food's getting stuck, or you're not going to be able to swallow, depending on how severe it is. If you have a scar around your intestine, it's going to be hard to pass gas potentially. It's going to be hard to have a bowel movement. So these are typically internal from some type of surgery. And when that happens, typically a surgeon's going to have to go back in there and revise that scar to kind of open up that lumen that way things can kind of pass through. So when it comes to repairing wounds, there's a couple ways that typically in primary care we're gonna try to repair them. That first is primary intention. That's simply, patient comes through, they have a cut, the skin edges are close enough, we're going to go in there and suture it. And what that does is it brings that skin together, that way there's not as much of that, those fibroblasts trying to connect to each other and create that granulation tissue that's going to cause that gray scar. If we can bring them close together, then we're going to allow the epidermis to regenerate a lot faster, a lot sooner, because you're going from a few millimeters to maybe half a millimeter to let those skin cells come together and reduce that amount of scar that can be made. Now, normally though, we want to try to fix these. If a patient comes in and they have some type of damage to their skin, we want to try to fix these within 6 hours. The reason behind that is because if you have a patient come in past 6 hours, that risk of infection goes up significantly, because you don't know what was going on, you don't know where they were at, things could have got in there, and so if it's been longer than 6 hours, then but maybe we won't try to close that with primary intention, because now you increase the risk of infection. And if you close that site that had the opening and there's stuff in there and you didn't clean it too, well then now that risk of infection goes up, and they're going to come back and it's going to look pretty bad. And it's not going to heal because you have this imprint off the skull. And then you got secondary intention. We typically reserve this for very large wounds. These are wounds that have very kind of jagged appearances. I mean, look at that knee right there. It's going to be hard to close that up with sutures, right? On top of that, typically these large wounds are from some type of pretty significant trauma or damage. So maybe the bacteria definitely got in there, dirt maybe got in there. So we don't want to close that wound up. We want to leave it open and let our body do its thing. We're going to go in there, we're going to wash it super well to try to reduce the risk of infection. But we want to leave these wounds open to let them heal on their own, like I talked about previously. And you see all that pink, kind of red, beefy looking stuff? That's that granulation tissue. That's those fibroblasts laying down that collagen. You got immune cells in there. You also got newly created capillaries, because we need capillaries. We need blood flow to that area to provide the nutrients we need for our skin to heal, right? So if you were to take a biopsy of it down below, that's what that would look like. And over time, those myofibroblasts are going to come. They're going to take the edges of that granulation tissue. They're going to bring them close together, try to contract that. You're going to get a scar, but then that epithelial cell is going to come over that granulation tissue and start to heal over it and then on top of it. So here's an example of secondary tension. So this was back in, it's pretty old, but so April of 2001, right? This is what it initially looked like. Then the next month down below, you see that it's getting a little bit smaller. And then by the third month, it looks pretty good. I mean, if you look at that, there's a lot of scarring. It's not all the way healed. It still needs a little bit of healing. But you got that granulation tissue that happened, got wounds contracting, and then those upper cells, those epithelial cells are starting to grow over. There's another example of that. This looks like it's probably on somebody's abdomen. The same thing. We had some type of injury, we can't close it, and so now we're going to try to close. We're going to let it heal by secondary intention. And I've had this happen when I was in England. I had a patient one time. She wanted to go to Poland to get a mommy makeovers, and part of that is what's called abdominoplasty. So she went to Poland. It was cheaper there, and she had her surgery, and she was very happy when she came back. But then she came back, and her abdominoplasty opened up on the sides. So then she came and saw me, and so I'm not a plastic surgeon. So I said, "What did your doctor say?" And she said, "He told me to come talk to you." I said, "Okay." So I called our surgeon upstairs, and I said, "Hey, this is what's going on. Can you see her? Is there anything you can do?" And the surgeon was like, "No, I'm not touching her. Like, she did that on her own. She needs to go back to Poland and see her surgeon." So obviously she didn't go back, right? So what I ended up doing was just, you're not gonna close this up, right? What I ended up doing was just have her come back, just making sure it didn't become infected, and eventually it closed. But unfortunately, she had a pretty nasty scar because that site opened up and it healed by secondary tension. All right. So when it comes to wound healing, some things can promote wound healing and some things can delay it. So obviously, the smaller the wound, the faster it's going to heal, right? If there are straight edges, like I talked about with the laceration, if we can bring that closer together, very easily we can heal that. If we can suture it together, it's going to heal pretty quickly. If it's jagged, it's going to be a lot harder. If you're going to try to repair that, you're probably going to need some type of plastic surgeon or somebody who specializes in like very detailed levels of suturing. If there's little tension on the wound, then they're going to heal faster, and that's what happened with that lady, the one I was telling you about. She had a lot of tension because they really tried to bring that tissue together, and it popped open, and so as a result, she had delayed healing. But if there's little tension on that area, well then it's going to heal faster. Also, when you see patients, when you get out there, patients are going to come to you because they're going to get cut somewhere, and they're going to get sutures placed somewhere, and then they're going to come to you to get those sutures removed. And if it's on the hands, be super careful. Be very, very careful, because if it's on the joints of the fingers, that can be deceiving. Because when you go and you look at a suture on the fingers and it looks like it's healed, well, think about, especially if it's on the knuckles, think about what they do all day. If they're flexing their finger and it's not all the way healed yet or healed enough, then once they leave your clinic, there's a high risk that they may come back because that suture popped, or not suture, but that wound popped open if you remove the sutures. So be very careful whenever you're evaluating a type of injury and you're thinking about removing sutures. There are time frames out there that tell you when the best time is to remove suture, so you'll learn that, you'll know that. But even then, sometimes somebody needs an extra day or two, so just be super careful. If there is good blood perfusion, obviously, if we have good blood flow going to that site. We're bringing in nutrients, we're bringing in oxygen. It's going to allow that tissue to heal faster. Good nutrition is super important. Vitamin C, zinc is needed to make collagen. So as long as we're eating healthy, a normal diet, then that's great. Negative impacts, so infection. Infection is the most important, most common reason for delayed healing. And when you have an infection, or when you have a wound, the big thing you have to do if you're going to close it up, the big thing you have to do is you have to irrigate that thing. You have to irrigate it with saline, and even if the patient comes in and they say, hey, I already washed it, doesn't matter. Make sure you irrigate that thing. Make sure you go through however much normal saline you need to make sure that that area is clean. So remember that. You got to irrigate it to prevent wound infection. You got to clean that site up. And if there's any bacteria stuck in there, especially if it's a lot, then that's going to propagate once you close that thing up, and then they're going to come back and they're going to have this big infection. And you have to open up that wound again and try to clean it out. Hopefully it doesn't go down too deep and cause other issues. Let's see here. Steroids. So I told you guys that inflammation is needed for wound healing. What some patients are going to do is they're going to come in because you gave them you gave them sutures, right? You put sutures in them, and then they started getting itchy from the sutures. And what they decided to do was put a little bit of steroid cream on them, steroid cream on the suture site to stop the itch. Not good. We need inflammation, right? We need inflammation to propagate healing, and steroids have an anti-inflammatory effect. So now, by them putting steroids on their cut, on their suture, we're delaying that healing, which means that when they come in for that suture removal, can you be for sure that you can remove those sutures, right? So make sure you tell your patients, don't put anything on that. Maybe Vaseline if you want to protect it, maybe a Band-Aid. Don't put any type of steroids because you're going to delay that healing and maybe cause issues later on down the line. Okay, and the complications of wound healing. So, wound dehiscence, that's what I was telling you. That's what happened with my patient. She had wound dehiscence. Essentially, when there's too much tension, when you try to close a wound, that wound site can pop open. And when it pops open, not good because it's very hard to close that back up. Do you want to close it back up? You've opened it up. How long has it been opened up? Did something get in there? So typically we'll let these heal by secondary intention. If you give those steroids like I talked about, you can impact that collagen formation, which we need that collagen to make that scar tissue to try to strengthen that wound closure. And then infection, like I told you, the big way to try to prevent that is to make sure you are cleaning that out. I'm gonna say it again, make sure you are cleaning out the wound to make sure it does not become infected. And then we can develop something called hypertrophic scars. So there's two types of scars, hypertrophic and keloids, right? Hypertrophic, all that means is that the scar is taller than expected, but it's still within those wound edges. So you have a wound, but it's not going over those wound edges, okay? Keloids, on the other hand, now these are a lot taller than what you would expect, and they go beyond that wound edge. So keloids are very they're not harmful, right? But for patients, they look unsightly. So oftentimes they'll come in and they want that treated. So if you see here, this patient had a keloid over his ear. He had treatment and they removed it. The problem with keloids, though, there's a certain way you have to do it. Because if you remove a keloid, if you cut it out, what do you think is going to happen? It's going to come back, right? It's going to come back, probably be bigger. So oftentimes when they're treating keloids, what they're actually going to do is they're going to cut it out, or potentially they're going to inject steroids into it to try to reduce that inflammatory process. So that's one way to treat keloids. Normally, if it's a small keloid, then you could probably do it yourself in clinic. With something like this, we're going to send to dermatology most likely for them to treat that because that's too big. And they're going to probably need that excised, and they're probably going to need some type of steroids as that wound's trying to heal, just so we don't put down as much collagen for that keloid to come back.
So I've seen a chemo get put on after they cut out a keloid, like
What's that?
like a chemotherapy
Okay.
to help with it.
Yeah, I mean, there's different ways to do it. I've never done that.
Yeah.
The only thing I've done in clinic was, because typically you'll have some type of steroid in your clinic. There's other methods though. There was a student here who gave her clinical inquiry on, I forgot what she said, but there was a new method they were doing that was very, very promising. Maybe it was that chemo.
Yeah, I used to do the injections for the steroids,
Yeah.
but they never wanted to cut them out. Like it'd be like a last resort to cut them
Yeah,
out.
yeah. Typically they won't. They'll try the steroid first, but for something like that, I don't know if the steroid would work. That's probably too big. So yeah, thanks. So that's pretty much it, guys. Any questions about what we're talking about today?
So what promotes movement better? Keeping the moist or drying it?
Say it again.
What promotes movement better? Keeping that side moist or drying it out?
So typically we'll keep it moist, and when we keep it moist, we'll keep it moist with Vaseline. So if you ever have to have a biopsy done, putting Vaseline over it helps really protect it. That's what you're doing. You're not so much keeping it moist per se, it's to keep bacteria out of it, that way the wound can actually heal efficiently. But we don't normally try to make wounds wet, it's more so of a protective mechanism.
But Neosporin are good.
So you can use Neosporin. When I worked with dermatologists, they didn't recommend it. When we do biopsies, for example, can you use Neosporin? Yes. The problem with Neosporin or with antibiotic agents is that some patients have reactions to them. And so especially if the site is clean, like say you did a biopsy, you controlled, you made it, you were sterile, you cleaned it off, do you really need to put Neosporin on it? Do you need to you kept it clean, all you need to do is just put Vaseline, and that keeps it covered, and then maybe a Band-Aid, and they're good to go. They shouldn't become infected. Now, if you have an injury that you cut yourself, right, and maybe it was dirty, but it wasn't enough to go and get seen for, well, then Neosporin may not be a bad idea. But if it's a clean wound, you don't necessarily need to put Neosporin or any other type of antibiotic protocol. Okay. Any other questions? Cool. I'll be up here for a few minutes if y'all have questions, and otherwise have a